Welcome to the DEBx Medical webinar, a practical framework for DEBRICHEM patient selection. Patient selection is not just a step in wound care, it's actually the difference between success and failure. Today we're going to talk about the most heard question for DEBRICHEM actually, which is, due to the wide indication of DEBRICHEM, what patients should I use to first try DEBRICHEM, and what patients are usable, are indicated for DEBRICHEM. We will zoom in a couple of wound types and discuss a couple of cases and why DEBRICHEM can help on these cases and how to select the patients for your clinic. I'm your speaker of today. My name is Hans-Pieter Snels. I'm the Clinical and Product Director of DEBx Medical, and I will guide you through this webinar. First of all, what's DEBRICHEM? DEBRICHEM is the product that we as DEBx Medical produce and is a chemical debridement agent for wound care. It's intended for non-surgical debridement and non-surgical infected wounds. That means that a chemical debridement for any chronic wound would be indicated. That is in need of a debridement at least. So we will explain a little bit about the mode of action on DEBRICHEM via a video and how that works by removal of the biofilm and necrotic tissue in just 60 seconds application of DEBRICHEM. In this video, we will talk about the mode of action. It's an animated video, but it will show you how it works and what it does. So 90% of all the chronic wounds that we encounter, they are infected with some kind of bacteria, planktonic bacteria that will set in and they will form a biofilm layer. A biofilm is actually something that matures in about half a day and will onset on the wound healing process. A biofilm will form, it will create a house where it structures itself with it's built up as an extracellular matrix, which is mostly made out of sugars and proteins, but also a very high content of water molecules. And now that's the trick. DEBRICHEM's mode of action is capturing water molecules. The ingredients within DEBRICHEM's gel, they will react with the water molecules in the biofilm, in the infected material. So DEBRICHEM binds with these water molecules, and it will dissociate and produce protons and energy that is eventually breaking down that biofilm, those sugars and proteins that are there that are impairing wound healing. So when DEBRICHEM is on that wound bed area, it will attract all the water molecules from that biofilm. So you see here that the water molecules bind to the DEBRICHEM molecules and there is an energy release that comes off. This energy release is so significant that it even causes bond breaking and unfolding of the proteins, losing their structure and function. This is also why there is a very disruptive nature of DEBRICHEM on that biofilm, on that infected material, and leading to that microbial death, eradicating the wound bed, the biofilm in the wound bed. Sorry. The bond breaking of DEBRICHEM on these molecules will give also a significant visible change to that wound bed area. This is actually the mode of action, capturing water molecules and releasing that energy, making a carbonization of the wound bed, which is that visible change that I was mentioning. This mode of action is very aspecific to any type of wounds. That makes it also a bit tricky to have a look in what etiology DEBRICHEM might be suitable. So DEBRICHEM works very consistently in all these types of wounds as long as there is a biofilm and necrosis, an infected material that needs to be challenged via a debridement. In this next video, I will show you a little bit more on that detailed aspect I was mentioning of that carbonization. So the mode of action of capturing water molecules is breaking down these bonds. In this video, will show you why the wound bed changes after the 1 minute application of DEBRICHEM. So we see here that biofilm formation again, and they are mostly made out of the bacteria that are present, and they are setting in there in the extracellular membrane matrix. And this matrix, as I mentioned, protein, sugars, fats, and mostly water. So we go into the biofilm where we denote these proteins and sugars, but mostly those water molecules. And then when we pour DEBRICHEM on there, it will react with the water molecules, as we just saw in the video of the mode of action. And this is the interesting part, because there, we briefly touched it already, the proton dissociation, where DEBRICHEM's molecules bind to the water molecules, release an energy. We remember this frame from the previous video. The energy release you notice there, which is the circle that is emitted from the DEBRICHEM molecule. And here you can see that the bonds really break within these molecules. And the breaking of those bonds, leaving only some carbon atoms in the wound bed, showing a significant change in the color of the wound bed after the DEBRICHEM treatment. So, looking at this, it's a specific method of debriding the wound bed via a chemical action. And we call this an advanced wound bed preparation. Now let's put that a little bit into a framework. Let's take the time principle framework. The time principle we know as the T for tissue, the I for infection and inflammation, the M for moisture, and the E for the edge. Where in the T, we would need to manage the tissues for the wound bed, where we need to manage the infection when we're considering the I of the time principle. And in this infection, there's most of the time also biofilm considered. And then we need to balance the moisture of the wound bed for proper wound healing. So we do not need to have a too dry wound bed, because that will slow down the epithelialization. And a too wet wound bed, we will encourage maceration, also impairing the epithelialization and therefore the healing. And this epithelialization that starts from the edges. So we need the edges also to be very healthy to move on to the wound healing phase. And this is what we call advanced wound bed preparation with DEBRICHEM. And we consider the T, the I, and the M, because we will challenge the tissue. We will create a very nice wound bed area with tissue. We remove the infection and inflammatory proteins, and the moisture is going to be reduced when the infection is also reduced, and therefore the maceration or too dry wound bed will not occur. But how does that actually work in clinic? So I have a brief video for you to show you how you would apply DEBRICHEM. After this video, we will move on to a couple of case discussions and wound type discussions for this webinar, as we're talking about the framework for the patient selection. But first, let's talk about DEBRICHEM's usage in clinic. So you create your wound bed preparation area where you want to prepare your working area, making sure that you have your clean and proper materials at hand, that you have your gloves at the ready, and then you undress the wound as you would normally do with a dressing change. You inspect the wound. You make sure that you inspect the potential exudate or whatever there is in the dressings left. You clean it with some saline, dry gauzes, assess how the wound bed is looking. This case was stagnating for at least 5 weeks. Then we look at this wound bed and we assess that this might have some potential to experience the burning sensation of DEBRICHEM. So we use a topical painkiller on the wound bed and the surrounding area to reduce the burning sensation that DEBRICHEM can give. As in chemical debridement, it might have a burning sensation. Then you shake the bottle of DEBRICHEM after the removal of the painkiller and put DEBRICHEM on the wound bed. That's where the clock starts for the 60 seconds of application. And within this video, we speeded up those 60 seconds. But you can see very well that you need to cover the peri-wound, the edges, and the wound bed area itself, making sure that you also get any planktonic bacteria that might form a new biofilm in the surrounding area. And then you simply rinse it off with some saline or sterile water, making sure that you have taken off all the DEBRICHEM, because that saline and sterile water, as we look back and the mode of action of DEBRICHEM, will therefore also neutralize its effect. And you saw the carbonization effect in this video on that wound bed after the 1 minute application, where it really changed significantly visibly. And then you just dress the wound bed as you would normally do, as this was a venous leg ulcer. We put on compression therapy. And then the patient can go home, where you can then reassess in the next dressing change. So, after the mode of action, knowing how to use DEBRICHEM, we now will have a look in the etiologies of DEBRICHEM. The patient selection, it varies by wound type due to the differences in these etiologies and the healing challenges that are occurring. The most common wounds that we see are venous leg ulcers, diabetic foot ulcers, and pressure ulcers. So we will consider those. But there is, of course, a very large variety of ulcers that we know from clinic, where the diabetic foot ulcer, venous leg ulcer, and pressure ulcer are the most common ones. But there's also the arterial ulcers, the post-trauma ulcers, and many other chronic wounds that you might think of. For today, we look at the first 3 items. In the patient selection, you need to consider a couple of things when considering venous leg ulcers. The most important considerations are that at least the wound bed should be stagnating for 4 to 6 weeks. There should be no response to any standard of care, and the wound is not progressing towards healing. This is already an indication of any infection or biofilm that might be present in there. So you look also for these signs of biofilm and infection. Maybe even some persistent inflammation or recurrent exudate, highly exudated wound beds, or very slimy wound surface, as they also indicate that a biofilm or an infection might be there, and therefore it's very suitable for a DEBRICHEM indication. You also want to evaluate the pain sensation for this patient, as DEBRICHEM, as I mentioned, has a bit of a pain sensation, burning sensation in the application. So we might want to consider a topical painkiller. And then we assess the history also for the full assessment of the patient to see if there is any response to the compliance of compression therapy. As it's venous leg ulcers, you also want to do the proper compression therapy, but also consider anything that might impair wound healing from a systemic or comorbidity point of view. So what we want to do is ensure that we have adequate perfusion, and also therefore the backflow, which is one of the most prominent problems with venous leg ulcers. And then we want to make sure that we know that there is an infection or biofilm that needs to be treated via a debridement, which we can do with a chemical debridement with DEBRICHEM. And then we consider the chronicity of the wound bed by the stagnation of the wound for 4 to 6 weeks at least, where there is no progression and it's marked as a non-healing wound with no response to the standard of care. And when we look at diabetic foot ulcers, it's a little bit of a different story there. We want to at least also have a look at that aspect of the chronicity, so 4 to 6 weeks stagnating to standard of care. And we want to also have a look in the signs of infection of biofilm, and where there is exudate or persistent inflammation, where then DEBRICHEM can definitely be of help. But with these diabetic foot ulcers, there is of course always a big risk of ischemia and neuropathy that needs to be checked and needs to be evaluated, as the ischemia should not be too large of an effect. And we can assess that via a Doppler assessment with the ultrasound or with a ankle brachial index. in making sure that we exclude the high level of ischemia, because we need vascularization for proper wound healing. And then with the neuropathy, we need to consider that as well, as that will be a problem with, for example, offloading, when the patient is not sensible to any new injuries that their new diabetic foot ulcer might occur. And then the last part, with a diabetic foot ulcer, because there is neuropathy, there is also a chance of osteomyelitis or exposed bone in a amputated site even. And this is something that also needs to be considered, that osteomyelitis is not something that we can treat with DEBRICHEM, as it's in the bone tissue. So that needs to be addressed properly before considering a debridement with DEBRICHEM. So we need to step by step select this patient by confirming adequate perfusion, vascularization, making sure that there is stagnation of the wound bed by a infected material, biofilm, necrosis, whichever. And then, of course, making sure that all the systemic factors like hyperglycemia or hypoglycemia is out of the question, and there is good control of the diabetes present. Then we have the last one that we were talking about, is pressure ulcers, where in the pressure ulcers, we also start again with checking stagnation to any regular standard care. 4 to 6 weeks. If there is no progression, then a DEBRICHEM treatment can be very useful. Looking to the signs of infection, biofilm present in there, and it can also be by foul odor. It can smell very badly. I think everybody knows, when considering a chronic wound, knows the smell of a chronic wound, and that it's not very pleasant. There can be a lot of persistent exudate, or even some persistent inflammation, and that the wound bed is not moving towards wound healing. Pressure ulcers can be also staged, and that's mostly considering partial or full thickness, skin loss, and most of the time it's due to a prolonged immobility of the patient, and therefore a prolonged pressure up to a point where there is no vascularization in that area, and then the ulcer occurs, and then biofilm can accumulate there, necrosis can accumulate there. So for a pressure ulcer, we need to also definitely consider the offloading treatments. So for these pressure ulcers, we definitely need to combine it with the offloading strategies to make sure that there is perfusion back towards the side of the wound bed. Now, just a quick intermediate break. I will give you one heads up. You can go to our website and sign up for a free demonstration at your own clinic, and one of our team will come and support you for a demonstration of DEBRICHEM. We will select with you a couple of patients, basically considering this patient selection guide that we will have. So please feel free to fill out your contact details, and we will contact you for a free demonstration at your own clinic. So now we're going to discuss some case studies on the real world application. So we have a venous leg ulcer case here. We went through venous leg ulcer, diabetic foot ulcer, pressure ulcer just now. So we'll take that order up again. Venous leg ulcer, a 3-month-old venous leg ulcer that is unresponsive to any standard of care. Compression therapy was not possible because the patient was not able to bear the compression. Therefore, we did a DEBRICHEM application and provided standard of care stockings, compression stockings with Vaseline gauze underneath. And after a full week, we also did a negative pressure on that wound bed during that first week, only 7 days. And after that full week, we had full granulation visible. So at presentation, we have this nasty wound with a lot of slough material. It's already exudating a lot, as you can see. And after 6 days of compression therapy, there is very, very good granulation going on, where after 8 days, there was a punch grafting, and the punch grafting had very much success. moving towards, at 8 weeks, full granulation, epithelialization also going on. And at 10 weeks, the wound was fully closed, making it a very successful case. So from a perspective of how to select a patient, 3 months, unresponsive, no compression therapy was possible. We assessed the case. We saw a lot of exudate, so we assumed a biofilm infection was present, which we needed to treat. And therefore, we did a DEBRICHEM treatment, making sure that we used the right care in the follow-up. And therefore, we were able to close this wound in 10 weeks with a grafting of a punch graft that was very successful. So keep that in mind in the patient selection, that stagnating and compression is very important for venous leg ulcers. Then we move to a diabetic foot ulcer. We treated a diabetic foot ulcer in a post-amputated wound site. So the first digit was amputated and this wound bed was not responding. So it was 4 months with recurrent infection and biofilm. The amputation was actually due to gangrene and ischemia. The DEBRICHEM treatment was part of a comprehensive wound care plan that was set up. So it's not the only aspect in this whole treatment of wound bed, but it was the one that was turning around the wound healing. The outcome of this case is actually that we have biofilm eradication, and this improved the wound healing trajectory, making the wound actually completely closed in 10 weeks. So at the presentation, we had this wound bed of the amputated site. It was yellowish, whitish in the first introduction. Then we treated that with DEBRICHEM, and the post-DEBRICHEM picture you can see here as well, where you can see that there is some blood flow, some vascularization in the wound bed area. So that one was covered in the selection, that we have good blood flow. And what we did here is also, before the DEBRICHEM treatment, we wanted to know if there is a biofilm present. So we took a moleculite device. A moleculite device is a fluorescence imaging device, and the fluorescence actually images the biofilm materials. So Pseudomonas, MRSA, anything that is in the wound bed present, the biofilm will light up in the fluorescence of the moleculite. In this case, we saw a very red ring surrounding that diabetic foot ulcer, and within the wound bed, very bright green colorization, indicating MRSA and Pseudomonas infection. You can also see here some materials that light up as well on the wound bed area. That is actually just the dry skin materials that are there, so like a little bit of callus on the foot and on the toe. They will always lit up a little bit, and the moleculite device itself assesses these bacteria because they have a specific wavelength on which they fluoresce. And you can see on the post-application picture that this full red ring, what we saw on the pre-debridement with DEBRICHEM treatment, that it was completely gone, and that the bright green of the Pseudomonas infection is also completely gone. And there is still some green fluorescence in the wound bed area and in the surrounding area, which is in a different wavelength and therefore not the Pseudomonas anymore. So, considering the patient selection, we assessed the vascularization of the wound bed of this diabetic foot ulcer. We assessed that it's stagnating for 4 to 6 weeks at least. And we assessed that there is a biofilm or infection present. And therefore we used DEBRICHEM to treat that. So following the treatment, we had some follow-up going on. And in 1 week, the wound bed was progressing quite okay. There were some granulation islands going on. And after 1 month, it was decreasing in size significantly. And as I mentioned in the beginning, after 10 weeks, the wound was fully closed for this patient. Then the last patient we will consider today is a case study of a pressure ulcer. As I mentioned, venous leg ulcer, diabetic foot ulcer, pressure ulcer, we won't move through those. And now we have the pressure ulcer. A stage 3 pressure ulcer came into the clinic. This was due to reduced mobility, due to many comorbidities the patient had. There were some persistent biofilm and necrotic tissue in that wound bed area. There was no tunneling found, and there was a minimal undermining found in the pressure ulcer, which was on the sacral area. And therefore, we treated the wound with DEBRICHEM and then followed up also with a proper offloading strategy and therapy. But also in the beginning, we did negative pressure wound therapy to promote the granulation tissue. And this was followed up by simple dressings for Vaseline gauze with the right offloading strategies. So we removed eventually the biofilm with the DEBRICHEM application. We have fast granulation going on due to the removal of any impairing structures and materials like inflammation, proteins, inflammatory proteins, biofilm infection, necrosis. And therefore, the patient comfort also increased a lot, making the patient more mobile and therefore being able to offload himself as well. Where we had full granulation in a very short time, and that full epithelialization was present in 8 months. As you can see on this picture, it was a wound with a lot of bad materials. It was not a good pressure ulcer. It was very large sized as well. You can see on the top hand side that there is a little bit of undermining, as I mentioned before. And then 15 days after DEBRICHEM, we terminated the negative pressure therapy. You can see a very nice beefy red wound bed area where already the size has been decreasing. You can see that in the clear shape of the wound bed area as well. And from there it started progressing even more, where after 1 month it was fully granulated and the size was reducing further on. And with it 8 months fully epithelialized, having it well done. For this was a very difficult case due to its immobility due to many comorbidities present. Meaning we assessed, in this case also for the patient selection, the wound is stagnating, there is biofilm present, infection present, there is the problem of offloading, so we need to address that as well for the proper follow-up therapy, and we removed all that infected material with DEBRICHEM's application in just 1 minute. I hope this helped a little bit in understanding how to select a patient. We have now some key takeaways of this webinar. DEBRICHEM is a tool for advanced wound bed preparation that will cover the T, the I, and the M of the time principle. And it's very suitable for various wound types as long as you make sure that the wound bed is stagnating and is not moving towards wound healing, has an infection or biofilm present, and all the other aspects that are more specific to the other types of wounds. An early intervention with DEBRICHEM prevents worsening of those wounds, prevents amputation, and will eventually accelerate healing towards complete epithelialization of that wound bed. And the importance of matching with complementary treatments, as we saw in the 3 live cases, is also something that definitely is to be considered, that we use the right negative pressure if needed, offloading for diabetic foot ulcers or pressure ulcers, compression for venous leg ulcers. As long as you do what the standard of care would say, then DEBRICHEM will surely help accelerating the healing process. So thank you very much for paying attention to this webinar. We have a patient selection guide now available for you guys. So please sign up for the patient selection guide to receive it, and you can read through the information as we just presented in this webinar as well on how to select your patient for a DEBRICHEM treatment. And you will see that all your patients that are suitable for DEBRICHEM will benefit significant And don't forget, as I mentioned in the break, you can sign up for a free demonstration in your clinic as well. And one of our team, maybe even I, will come to you and help you out in selecting patients, treating patients, and giving you the right tools for chemical debridement. Now let's move on to some questions. Can DEBRICHEM be used in both inpatient and outpatient settings? The short answer, yes. DEBRICHEM is a chemical debridement agent that is neutralizing the biofilm and infection in the wound bed. This is not specific to any treatment place. Most of the time we see that wound treatments are in ambulatory setting, dressing changes, quick, sharp debridement, and then putting on a new dressing, and the patient goes home. And that is a perfect place where DEBRICHEM can be used. However, when there is a very complex diabetic foot ulcer that needs treatment to the osteomyelitis by amputation, there is a soft tissue infection and biofilm present that needs to be managed, DEBRICHEM can also be used in the inpatient setting, in the hospital bedside, or even in the OR, making sure to completely eradicate that biofilm from the wound bed, making sure that there is a clean area of wound healing to start. So it can be from inpatient OR setting to the ambulatory setting, but also even in the home care setting. We have some experience in the Netherlands where we treated a lot of patients in the home care setting with DEBRICHEM. Just put a couple of blankets and drapes under the wound bed area, and the patient can be comfortably in their own bed. DEBRICHEM on there for 1 minute, rinsing it off, and that's it. So no, there is no specific setting where DEBRICHEM can be used. Do be aware that DEBRICHEM is a debridement tool. Next question coming in. Does incorporating DEBRICHEM require any changes to current wound management practices? Basically, the answer is no. Whenever you would do a debridement, the debridement can also be now with DEBRICHEM. So the only change you need to make is the steps of use of DEBRICHEM itself. So making sure that you leave DEBRICHEM on for 1 minute, making sure that you put DEBRICHEM on the peri-wound, the edges, and the wound bed itself, so that you cover everything to also prevent any new contaminations or and killing off any planktonic bacteria that are on the wound edges and the peri-wound area. And then rinsing it off with enough saline or sterile water, as that will neutralize the effect of DEBRICHEM. And this will take only 5 minutes. So within the process of wound management, in the practice, the patient comes in, you take off the dressing, you clean the wound, you have a look at the wound, you assess it, you make sure you document what you see. And then when you would do a debridement, you can now also use a chemical debridement with DEBRICHEM. Then after the debridement with DEBRICHEM that you rinsed off, you clean up the wound bed, and then you dress the wound bed accordingly to your standard practice, standard protocols. This is therefore very easy to have DEBRICHEM incorporated in the wound management practices. How does DEBRICHEM interact with other treatments a patient might be receiving? This is a good question because DEBRICHEM is a topical chemical debridement. It does not have any effect systemically. There is no absorption, there is no metabolic effect, no pharmacological effect. And after 1 minute of application, you use sterile water or saline to rinse DEBRICHEM off the wound bed, neutralizing the full potential of DEBRICHEM's ingredients. So, after the 1 minute, there is nothing left of DEBRICHEM in the wound bed, which means that any other treatments that the patient might be receiving are not having any effect when they are in touch with the wound bed area. So for example, a compression therapy or a negative pressure therapy or a silver dressing or an alginate dressing, any of those will not have any effect by DEBRICHEM because it's completely neutralized after that 1 minute application. That means that any type of dressing, any type of treatment for the wound bed itself is not contraindicated due to the application of DEBRICHEM. That means that you can just complete your standard protocols in your clinic for these types of wounds that are indicated. A question coming in. How frequently should DEBRICHEM be applied during the treatment process? DEBRICHEM is a single-use device, so you'd use DEBRICHEM only once during the treatment process. You use DEBRICHEM for 60 seconds on the wound bed, and then you have eradicated the biofilm. You are sure that the wound bed is clean and can start moving throughout the wound healing process. However, it might be so that a new infection may occur in 6 weeks or in 2 months or in 3 months when the wound healing was not fully finished. And then there is a new infection that needs to be treated because the patient was not following regimen. There was a systemic infection that occurred, which now also made a wound to be infected. We've heard stories that the dog was licking the wound during the dressing change. So anything can happen, making a new infection present. And then if we have gone through the patient selection steps, DEBRICHEM may be indicated. We can do a treatment with DEBRICHEM to treat this new infection and this new wound. Making sure that we have a new setup for wound healing progression. And with that, we come to the end of our webinar today. And thank you very much for paying attention to this. If you like the content, please do follow us on LinkedIn for updates on newer webinars and other educational content as well. With any other queries, just go to our website and reach out. And don't forget, you can also get a free demonstration via our website.